Hello everybody. I think you've probably heard that I am a clinical scientist. I work in the renal unit in Leeds in the UK. I've been working with bioimpedance for the last 20 years, and I'd like to tell you what I tell our nurses about using the BCM and hope that that is useful for you. So when I introduce bioimpedance, I explain that it's a measure of how difficult it is for an electric current to pass through a biological object. And people have used bioimpedance to look at many different biological objects. What we're normally interested in is a human being. It's very sensitive to the amount of water in the tissues, which is why it can be used to assess the fluid status of a patient. The Fresenius body composition monitor uses impedance measurements made between the wrist and the ankle and two mathematical models. The first model it uses calculates the patient's intracellular and extracellular fluid volumes. The second estimates how much extracellular water they would have if their kidneys were being normally hydrated. So a little bit about how it works. Impedance has two components called resistance and reactance. The BCM makes impedance measurements for currents with 50 different frequencies and displays each measurement as a dot. The position of the dot depends on the amount of resistance and reactance measured between the wrist and the ankle at the particular frequency used. The dots form an arc called the Cole plot. It's named after two brothers whose surname was Cole, who first described it. And there are good scientific reasons why the dots produce this shape. But today we'll just look at the two most informative dots. The first is the last dot on the far right of the Cole plot. And that's the measurement with the highest frequency, the highest resistance and the lowest frequency. It's the lowest frequency because low frequency currents struggle to get inside cells. They can't pass through the walls of the cells, so they mainly travel through the fluid between the cells. The harder it is to get through the body in the extracellular fluid, the further right this dot will be because it's more resistance, more difficult. So it's easier for currents to pass through tissues containing lots of fluid, which I've drawn on the left there. So if you have less fluid, you'll become fluid depleted, that will move the dot to the right of the plot and move the whole plot to the right of the screen. It's also easier for currents to pass through limbs with a large cross-sectional area. So thinner patients are further right than larger patients with the same hydration. So if you have a thin patient, their plot will be on the right of the screen, a large patient it will be towards the left. But the actual position depends on the combination of both shape and hydration. The other dot I want to talk about is the dot at the top. The uppermost dot in the arc is the measurement with the highest reactance, and it's got a frequency of around 50 kilohertz. Reactance tells you how much work the current is doing to take a shortcut through the cells. The more work the current does to get into the cells, the higher up this dot will be. So the current is going to work harder to get into the cells when it's harder to get through the extracellular fluid. So the further right the Cole plot is, the more resistance there is, the harder it is to get through the extracellular fluid, the taller the Cole plot will be, the higher up the reactance will reach. But currents can only pass through cells that contain water, which is muscle cells basically, because fat cells don't conduct electricity, they contain triglycerides. So a patient with a high percentage of body fat will have a shorter Cole plot. And this is usually due to patients having not enough muscle rather than too much fat. They've just got a high proportion of fat. So to put that all together, if I start with 3 female patients who are all normally hydrated, they aren't either fluid depleted or overloaded, and that could be people in this room as well. If I take a female patient with a normal body mass index, they've got a plot in the middle of the screen. If I move to somebody who's got a high body mass index, the plot moves to the left. You can see how much they've moved across. If I go to somebody with a low body mass index, the plot moves a long way to the right. So the far right point of their plot has gone right off the screen here. Now if I take my patient with a normal body mass index, at normal hydration, they're still in the same place. But if that patient is fluid overloaded, it now becomes much easier for the current to get through the cells, between the cells rather. So everything moves over to the left-hand side. Whereas if the patient is depleted, dehydrated, now it's much more difficult for the current to get through the tissues because the cells are much closer together. And now we've got a plot which is much further over to the right. Can everybody see how that's happening? If you need to make a way of remembering it, this is what I tell people to do. Remember that going down and left is related to being overweight or overhydrated. Going up and right is related to being underweight and underhydrated. So you can think of that as a seesaw. So if you're light, underweight, or underhydrated, you're up at this end. If you put weight on or put fluid on, you move down. Yep. Changes in bioimpedance with hydration, these changes that you get moving up and down, they're very large often and they're very reproducible. But you don't want to just look at a cold plot because most people like to have a number as well. So, and for numbers, this is why we need the model. So you can actually tell a lot about the patient just by looking at where their cold plot is, but now we need to translate that into amounts of fluid. Oops. Okay, so how do we get from the cold plot to body composition? The first thing we need is the fluid model. And for the fluid model, you take the information from the cold plot, the weight and height of the patient, you use the fluid model, and that gives you the extracellular water and the intracellular water. You then use a body model, again with the weight, but now with the extracellular water and intracellular water, and that tells you how much lean tissue and adipose tissue the patient has and how much under or over hydration they have. And these are the two papers that you can read which explain how you get from here to the fluid model and here to the body model. So from that paper that told you about the body model, that showed that lean tissue and adipose tissue have different but constant water properties. So here's normally hydrated lean tissue, and it has about 70% water. And do you remember that I said that muscle cells have water inside? And about 2/3 of the water that's in lean tissue is inside the cells, and about 1/3 of the water is outside the cells in the extracellular water. Whereas if you look at adipose tissue, there's much less water, and now the proportions are the other way around, with only about 1/3 of the water being inside and 2/3 being outside. The actual proportions are a commercial secret inside the BCM. So what's important is that excess fluid adds to the patient's extracellular water and to their weight. It doesn't go inside the cells generally. So any combination of extracellular water, intracellular water, and weight actually have a unique combination of normally hydrated lean tissue and adipose tissue and either excess fluid, overhydration, or fluid deficit, dehydration. So here we've got a patient with 17 litres of intracellular water, 18 litres of extracellular water. Now she should only have about this much extracellular water, really, because if she was normally hydrated, that would be too much for her body, which the model will say oops, gone. The model will say is about 37 kilos of lean tissue and about 15 kilos of adipose tissue. So that extra weight of excess fluid, which has gone into the patient's body, is actually going to be overhydration. So in this case, the patient's got 5.5 litres of overhydration, and if they had less fluid than they should have, then her lean tissue and adipose tissue would be slightly too small, and that would be negative overhydration. So just looking at that again, you can think of normally hydrated weight as adding together the amount of lean tissue and adipose tissue in the body, or you can think of it as the body weight with the overhydration subtracted. If we're going over here and looking at dehydration, the normally hydrated weight is the lean tissue mass and adipose tissue mass, but now they aren't normally hydrated, and we need to add the dehydration volume. So we have to add the dehydration to the lean tissue and adipose tissue mass to get the normally hydrated weight. Okay, so that's all I'm going to say about the theory, and I hope that helps you to understand mainly where you would expect the coal plot to appear on the screen, so you're not surprised at where it appears. To be practical, when you want to make a bioimpedance measurement, the first thing you need is a height in centimetres. And if the patient can stand up, then that's fine, we measure the actual height. We use an estimated height if the patient is in a wheelchair and can't stand up, or if they're kind of curled up. A lot of our patients are more like this than like this. We're actually looking for something to represent the length of the body in the model. So what we want is the height of the patient when they could stand up straight. I usually ask the patient, and they might say, oh, I was 180 centimetres when I was in the army, and then I take off 2 because usually people shrink a bit when they get older. If you don't have a previous height for the patient, either from their medical records or from talking to them, your dietitians will have a preferred anthropometric measurement, and you should use that. For amputees, you're looking for their unamputated height, so you will again either need to ask them how tall they were before they were amputated, or use the anthropometric method. Once you have their height, you can make a fluid management tool card for the patient. At the moment, we're using Fluid Management Tool 3. I believe that version 4 will be released soon, but my slides relate to version 3. You need to, on the card, you'll need to put the patient's date of birth, gender, and their height. But once you've done that, you won't have to keep entering them again. So that's why it's a good idea. One reason why it's a good idea to have a pre-programmed card. If you can then put the data into the fluid management tool, it allows you to both view the coal plot, and I'll show you why it's very important to be able to do that in a moment, and also to confirm that changes in the body composition are part of a plausible trend rather than a poor quality reading. So this is data for a patient who had gastric bypass surgery. He was initially nearly 150 kilos and was not eligible to have a transplant. So he had surgery, and you can see how his adipose tissue decreased, but his lean tissue actually increased. And there's a smooth change in his tissue. Apart from here, whoops, I haven't said it on. Apart from just here, which is where we actually made 2 different measurements at the same time, one hand to foot and the other one hand to hand. So you can see how there's a difference in the relationship between the adipose tissue and the lean tissue depending on the electrode configuration. Otherwise, it's nice and smooth. Oops. The main thing you need to tell the patient that we're going to be putting electrodes on their hand and foot for most people. Most patients are happy for you to slip off their socks, provided you don't tickle them. But tights are awkward, so ask patients not to wear tights because it's difficult to take them off in the dialysis unit when they're going to have a BCM measurement. Also, if you can, ask them not to apply cream or ointment to their hands and feet before the measurement, as it's going to need to be wiped off. For the timing of the measurement, with hemodialysis patients, it's usually best to make measurements pre-dialysis when they've been weighed and are sitting or lying down. You can make measurements post-dialysis, and for that you may need to estimate their weight and make a correction later if the patient finds it difficult to transfer between the dialysis chair and the scales. When it's good to make post-dialysis measurements is if a patient has experienced severe symptoms. For example, they've had a lot of cramp, they're feeling dizzy, and that could have resulted from excess fluid removal. If you measure them post-dialysis, you can confirm that they're fluid depleted, reassure them that it won't happen next time because you'll put their target weight up, and tell them that they can go home and enjoy maybe a litre of their favourite beverage. And patients are often pleased to hear that, and it makes up for the cramp. The patient's normally hydrated weight may differ if you measure them pre or post-dialysis because of changes in electrode and temperature, electrolytes and temperature. So don't be surprised if on one day you happen to measure a patient both before and after dialysis and you don't get exactly the same difference as the ultrafiltration rate would tell you. That is to be expected. Now for PD patients, you can make measurements during clinic or home visits, and it doesn't matter whether the patient is full or empty, because the BCM mainly makes its measurements from the arm and the leg, because the cross-sectional area of the trunk is so big, it's very easy for the current to get here, and it doesn't contribute very much to the measurement. The next thing you need is the patient's weight. For a hemodialysis patient who comes to the unit, weigh them just as you would when recording their pre or post dialysis weight. So whatever you do for shoes, for clothes, use the same as you would do for recording their pre and post dialysis weights. For home hemodialysis patients who are having a BCM in clinic, it's best to ask them to weigh themselves on their own scales just as they would be for dialysis just before they leave home, because you're going to use the measurement to make a target weight and you want them to be the same as they would be just before dialysis. For PD patients, you need their empty weight, so their drained weight. So they need to weigh themselves after draining out or with a known volume of fluid in the peritoneal cavity that you can subtract. And again, because they're PD patients and they look after themselves at home, this weight is best done with their own scales. Now, the wrist to ankle measurement, as I said, is mainly from the arm and the leg, which have the smallest cross-sectional area. Now that means that the presence of fluid in the peritoneal cavity, in the lungs, in the stomach, in the intestines, or in the bladder, has little effect on the measured hydration. And that's good if it's fluid that can't be removed on hemodialysis. So, for example, a patient with ascites will have fluid in their peritoneal cavity, but it's not fluid that you can remove on dialysis. So if you try to remove, if you include that in the weight and try to remove it, you could make them unwell. So the BCM can tell you how much fluid is actually available to be removed. But it does mean that you can't use the BCM to diagnose fluid in the lungs or in the peritoneal cavity. So you can't use it to diagnose either ascites or pleural fluid. So any free abdominal fluid adds to the weight, but not the hydration. So in hemodialysis, if there's any free abdominal fluid, so that say the patient has just drunk a lot and they've got a stomach full of fluid, that could lead you to try to remove too much fluid in the same way as heavier clothes or forgetting to remove shoes can. And that's why you need the empty weight for PD patients, even if they're full when you make the measurement. So does that make sense? The BCM's looking at the arm and the leg, so it doesn't matter what's in here, so we don't want to include the PD fluid. Sometimes you can't weigh the patient at all. So you have to, this is patients who are too unwell to get onto the scales at all. So with those patients, you need to use a guessed weight to check their hydration and decide if the UF goal in patients who are too unwell to, decide what UF goal to use in patients who are too unwell to weigh. The OH reading is actually fairly constant even if you're several kilograms out in weight. So if you try making measurements on yourself and program it with different weights for yourself, you'll find that the overhydration reading doesn't change very much, but the amount of body fat that the BCM thinks you've got will change a lot. Oops. Just one thing, what I would normally do in this situation, if I'd never met this is an acute patient that I've never met before, I think of a patient that I know who looks similar and I borrow their weight. So that's a trick for patients that you can't weigh. After getting their weight, you need to lie the patient down. And this is because gravity affects the distribution of fluid in the body. And the BCM models were developed using supine patients. It takes a while for the fluid to settle into a new distribution when you change position. So if you imagine standing on your head, after a little while you start feeling the fluid in your face. So as soon as possible, adjust the bed, chair or couch so the patient can lie down as flat as they can comfortably go. Most patients prefer to have their head on a pillow if one is available. If not, set the backrest at a similar tilt to a pillow. If the patient can't lie down, find a comfortable compromise. So it's just the best you can do with that patient. And remember that if the patient is tall and on a chair, you're going to need to extend the footrest so they can stretch their legs out. Because a lot of chairs have a metal rim around them, which you don't want them to be touching. Then you have to decide which electrode configuration to use. If the patient has a working, maturing or planned fistula or graft, then use the hand and foot on the opposite side of the body unless it's contraindicated. If they've got no working, maturing or planned fistula, then use the hand and foot on the dominant side, again, if not contraindicated. Contraindications include amputations, large dressings, severe localized edema, such as venous outflow stenosis, giving you a swollen arm, if that's on the preferred measurement side. So if you can't use the ideal measurement side, the next choice would be hand to foot on the fistula graft or non-dominant side. But you can also measure across the body, so this hand to this foot and left hand to right foot. So those will all give very reasonable readings. And if you need to, you can also measure hand to hand. So you can connect any two extremities except for the 2 feet. So this measurement doesn't work. All the others are fine. Importantly, though, you should stick to the same configuration when you want to monitor trends. Because even though you might not get the same absolute reading for the patient's normally hydrated weight, the trend will still work provided you keep to the same electrode configuration. So we would treat hand-to-hand measurements as less accurate than those made with a more standard configuration, but still a good indication of severe or over or under hydration, and they're just as good as standard configurations for monitoring trends and changes. Now we want to prepare the patient for the measurement. So we remove watches or metal bracelets from the arm in the measurement pathway. They probably won't make a significant difference, but may make measurements less reproducible. Leave rings on fingers because they aren't in the measurement pathway, but move any wires, the nurse call, bed chair controller away from the patient. This is probably the most important thing I can tell you. Always prepare the skin of the patient. If they've moisturized their skin, wipe away the cream or lotion with an alcohol-impregnated cloth or swab. If you leave a residue, the electrodes won't stick to the skin, and even if they do stick, the reading will usually be unstable and inaccurate. If they aren't moisturized, massage a little alcohol gel onto the back of the hand and the top of the foot where the electrodes will be placed. even if the skin doesn't appear dry, the contact with the electrodes will improve if you just prepare. It just takes a few moments, and patients quite like the little massage, so it's well worth doing. Now we need to position the electrodes. The tab should point outwards, and we use the bones of the wrist and the ankle to position the proximal electrodes. And this is to help ensure that the electrodes are in the same place for each measurement. So if I can do this while I'm holding the microphone, I would put my fingers on the wrist bones and hold the electrode in the same hand and position the electrode between my fingers. That works very well for getting the electrodes into the right place. Okay, I've swapped over now. The outer electrodes, the distal electrodes, should be placed near the fingers and toes as shown. I just put them on the nearest flat part of the skin to the knuckles or the toes. They need to be at least 3 centimetres from the inner electrodes though. And sometimes you have to adjust the electrodes to avoid damaged skin, but still try to keep them as close as possible to your ideal position. Oops. Come on. Why are we going the wrong way? Okay. So now we have to connect the patient leads. It doesn't matter which lead goes to the hand and which one goes to the foot. You just need to position the BCM so that the leads will reach the electrodes and so that they can get there without being tangled up, twisted, or passing over metal objects. You need to place the red clips on the outer electrodes and the black clips on the inner electrodes. And what I tell the nursing staff to do is to imagine red nail polish when placing the clips. So you imagine the red nail polish and then put the clips closer to the nails, yeah? Then you need to position the patient. We normally aim for a stick man position with the arms away from the sides and the legs and feet slightly apart to avoid unwanted current pathways. The unwanted current pathways are mainly here and here. If the patient is wearing a skirt or a nightdress, you just need to check that their thighs aren't touching. And you need to check there's no contact between the upper arms and any part of the chest. I think in Korea, most of your patients will be good in the stick man position, but we often have to ask our bigger patients to kink their elbows out. So we have stick man and monkey man. And the patients get quite used to, you say, monkey man, please. They do it. So if necessary, you can use pillowcases, towels, cushions, cuddly toys, or clothing to achieve that separation. You just need to be absolutely certain the current can't sneak across here or here. Now, having fixed the electrodes in place, this is the time to enter the data. It's better to get the patient lying down as quickly as possible so the fluid in the body can settle, and the electrodes on the skin as quickly as possible because the contact improves with time. If you have an FMT card, you only need to enter the weight. If you're measuring pre-dialysis, you can enter the patient's blood pressure, but it's not required for the measurement, so it doesn't matter if you haven't got it. And if you've got a post-dialysis blood pressure, or if you're measuring post-dialysis, the blood pressure can only be entered when data is saved on the FMT because it will automatically be treated as a pre-dialysis blood pressure if you put it in. I advise our staff not to enter an ultrafiltration volume. If you're measuring the patient to see what their target weight should be, you won't know, and I think it just causes confusion. So we now want to make the last minute checks of the patient before we make the measurement. We need to make sure the electrodes and the clips are in place, that the cables are not tangled and they're separate and not tangled, they're not running over metal objects. The patient's still in the right position, and have a good look to make sure the current couldn't find an alternative pathway, and make sure they're not touching any metal, such as the frame of the footrest, and some dialysis chairs have a kind of metal band underneath the armrest, and with a larger patient than this lady, they often have their fingers over the end and onto the metal. So now you can start the measurement. You need to ask the patient to keep still and quiet until the cold plot or an error message appears. The BCM will run through measurements for 50 frequencies twice and then display the cold plot. You might get a movement or electrode error. A movement error occurs when the runs through the first and second 50 frequencies don't match. You'll get a measurement failure. The electrode errors could be due to a problem with the electrodes or leads, but lots of other things cause them. So if you get a measurement failure that says check the cable and electrodes, it could be a problem with those, but touching metal is one of the things that can also give you an electrode failure. And not all quality problems actually generate an error. Sometimes you'll still get a cold plot even though you've got a problem. Oops, sorry. So you get your cold plot on the screen, and in the top right corner you get a thing called the Q reading. Now that reflects how far the measured points are away from the fitted curve as the BCM is trying to fit the curve. So small cold plots where the dots and the fitted curves are all squashed together can have high Q readings when there's clearly a problem with the data. I'll show you one in a moment. And tall cold plots where the dots are spread out give low Q readings even when the data is good. So I would say that this Q is not a measure of quality. And what is the best quality measure we have is a well-shaped symmetrical cold plot. We also wanted the measurement to be reproducible, realistic, and consistent with historical readings if we have any. So the cold plot should be symmetrical. You can often see more of one side of it than the other, so you have to imagine the side you can't see. It should be like an arc or a rainbow. It shouldn't flick upwards at the sides or outwards. And you might have to guess if you have a good cold plot, because part or occasionally all of it has actually gone off the BCM screen. And the great thing about using the fluid management tool is that you will be able to check it when you view the data in the fluid management tool. So in this case, most of the data is actually off the right-hand side of the screen. So this would be data for a patient who was either very thin or a patient who was not so thin but now dehydrated. So here are some examples. This is the kind of upward flick that we've often used to get before we did routine massage with alcohol gel. And this is a couple of months later when we'd started doing the routine massage, same patient, and you can see how much better their cold plot is. This is what happens when the patient puts their toe on a lot of things could happen, but in this case what we got was a left upward flick of the cold plot when the patient was touching metal, and this is the cold plot when they took their foot away. This plot was very distorted due to contact between the arm and the chest of the patient, and it gave a very unrealistic overhydration of -9 litres. No human being could lose 9 litres of fluid and still be alive. They would go into shock. What had happened here was this was a lady with a large chest who was wearing a very light nightie, and when she laid down, her chest moved round to the side. So we respectfully resolved the problem with pillowcases under her. She held pillowcases under her arms, and then we got a nice cold plot, still very small, and an overhydration reading of plus 7.2 litres. And that was consistent with the clinical picture and the position of the cold plot. So remember, with the seesaw, overweight and overhydration, she was very overhydrated, 7.2 litres. So she should be down in this bottom corner. That was all what we'd expect. Now, what we can also see from this is that the Q reading was 87% for this cold plot, whereas for this one that I showed you earlier, it was only 79%. So the shape of the cold plot is a much better measure of quality than the Q reading. And in fact, with that patient, with this particular patient, all you'd be able to see on the BCM screen would be up to here, and you wouldn't see that nice cold plot until you actually upload the data into the fluid management tool. Okay, so if you get an error message or a distorted cold plot, you need to repeat your last minute checks, make sure everything's okay, make absolutely certain there's no cream or ointment on the skin. If you wiggle the electrode and it moves easily, they've still got a residue of cream or ointment. I tend to smooth the electrodes down to try and ensure good contact. I don't know whether it does any good, but it makes me feel better. If the patient has very paper-like skin, so we get this a lot in our South Asian ladies, very elderly ladies who have skin that feels like paper. It doesn't seem to be very well connected to the flesh inside, so we move the electrodes onto the inside of the hand where you have a lot more flesh. And we do that with the ladies who have, or the people who have very papery skin, but if you've got somebody who's got very hairy wrists, that also can cause problem with the electrode connection, and they might like you better if you put the electrode on the inside rather than the back of the hand. Sometimes you can't solve the problem, the cold plot won't become symmetric, but you can still let the BCM find the overhydration and then make the other checks that you can for quality. The first one is reproducibility. So, oops, it's gone the wrong way again. So for reproducibility, we always repeat the measurement. Even if the cold plot looks perfect, we still repeat the measurement at least once. If you get a small difference between the first and second reading, it means that probably means that the fluid is still settling. I accept a difference of about 0.2 litres in overhydration readings that are relatively close to zero, say between plus and minus 2 litres. A difference in overhydration of up to 10% is okay when the reading is further from zero, if the cold plot is not too distorted. If I've got a reading of 5 litres and 5.4 litres, I would accept that. Larger differences indicate that the current has found an inappropriate path between the electrodes. And these inappropriate, unwanted pathways are usually unstable, so that causes the calculated overhydration to jump about. So this is an example where we needed to do this. So this cold plot is actually distorted on the right-hand side, and the model is much more sensitive to distortions on the right side than it is on the left. It's hard to see the distortion until you see, can you see the difference between those two? This one's a little bit, it's moved in a bit, and it's now a nicer shaped arc. And but the way we could tell that we had a problem was that the reading went from plus 2.7 litres to plus 4.4 litres 2 minutes later. So we could tell that there was a problem. The third reading was also plus 4.4, so we knew that that was a good reading. The other clue we would have had is that the fluid management tool would have told us from this reading that the patient had gained about 10 litres of muscle since her last measurement, and this would be very unusual for a dialysis patient in hospital, which was the case. So what we would have had was readings which are inconsistent and readings which, unreproducible and also not consistent with the previous measurement. So that lean tissue mass we check, we often do that when a patient has a relatively symmetric cold plot, but it's flicking up a little bit on the left-hand side. And the BCM, when it's fitting, it can ignore a few points, and it seems to manage to give us good readings, even if we've got something which looks like this. The way we can tell whether that's good quality or not is to check the reproducibility. We made 3 measurements and they all gave minus 1.5 litres. We could also see that the cold plot was higher up and further right than the previous readings that where we'd had the patient close to normal hydration. And the lean tissue mass was consistent with the previous reading, so there hadn't been any change. So even though the cold plot wasn't symmetric, the other 3 measures we have of quality were good, so we accepted that reading. I need to just give you a word of warning before we look at some examples. The BCM gives its best estimate for the patient's normally hydrated weight, i.e. their weight with normal kidney function. But the BCM has to make some assumptions about the shape of the body. And if I measured all of you, everybody in this room, most of you should be, I hope, normally hydrated, unless you've been denying yourself fluid all day. So you should be normally hydrated, but you wouldn't all come out with a 0 reading on the BCM. The closer you are to being typical of the population that was used to make the body model that the BCM uses, the closer your overhydration will be to 0. The difference between your actual weight and your BCM normally hydrated weight is your BCM offset. So if I measure myself and the BCM says I am plus 0.5 litres, it thinks I have 0.5 kilos of excess fluid, so it would give my normally hydrated weight as, say, if I told it I was 63 kilos, it would tell me I was really 62.5 kilos, and my offset would be 0.5. The BCM can aid but not replace clinical assessment when assessing an individual patient's target weight. So it's giving you its best estimate of the patient's normally hydrated weight. The patient, like everybody else, will probably have an offset that you have to imagine because you don't know what it is. So it's not an absolute, the number that you get isn't precise, and you always need to make sure that you think about the clinical assessment of the patient as well as the BCM reading when you're setting their target weight. So I was asked to provide some examples of real patients. So I have pictures of 2 real patients and one who looks like a real patient. So this is Katie, who you saw when she was demonstrating what happens when you put your foot on your toes on the footrest. This is TK, who you saw as an example of a patient who has contraindications to a normal hand-to-foot measurement. This is not the real NG, but the real NG did look a bit like iced tea, so I've used a picture of iced tea to give you an idea of what his body composition might be like. So KT. KT started dialysis when she was 12 years old. She was on CAPD for 11 years, which was probably too long. In 2009, she reluctantly converted to hemodialysis and unfortunately was diagnosed with encapsulating peritoneal sclerosis a few months later. Have you had cases of EPS here? Yes, same as us. Katie was she was small because she'd had renal failure for so long. She was already under 45 kilograms, but dropped to 32 kilograms during a long stay in hospital. And that's the point at which she dropped to 32 kilograms. When Katie was normally hydrated at 32 kilograms, her coal plot was here, and this is what shows on the BCM screen. So none of the dots at all appeared on the BCM screen. The next slide is going to show you how her coal plot appeared when she was 4 litres overhydrated, but she'd actually gained some weight and her normal hydration coal plot had moved back towards the middle of the screen. So here she is at 38 kilograms with no excess fluid. Now, she's underweight, but what happened when she's overhydrated, so she's going to move down the slide, down the seesaw. And that's where her coal plot was with 4 litres on. So you can see how, if you just looked at that without getting a measurement at all, you would know that she was going to come out very overhydrated because that's where her coal plot should be. In TK's case, this is a gentleman who started APD in 2005 but then converted to hemodialysis. He had his right leg amputated in 2007, his left 2 years later. So by the time we'd actually started doing BCM measurements, he was bilateral amputee. So we measured him hand to hand. I estimate that his BCM offset was about -1 kilo. Just from all the measurements I made on him, I think that that's where his offset would have been. He didn't want to increase his target weight in September 2010 because he was finding it harder. He was finding it harder to transfer independently. So he liked to be able to move himself, and when he was putting on weight, he was finding it hard to transfer, and he wanted to diet instead of having his target weight increased. And I can show you on the next slide how his coal plot changed when he was 4 litres underhydrated. So I might have to come back to this slide. So this is TK at 115 kilos, normally hydrated. And you can see because he's a big man, his coal plot is over on the left, probably in about the same place as KT's was, but taller. Now, if he's overweight but underhydrated, underhydration is going to move him up his own seesaw. So what we got was, doesn't move as far as KT's went, but we can now see that when he's missing 4 litres of fluid, we get a movement up and right, the same as we got down and left with KT. And I also want you to have a look at where the top of his coal plot when he was normally hydrated. So at the top of his coal plot, his highest reactance when he's normally hydrated is about 40. Oops, come on. So that can bring me on to NG, our iced tea lookalike. He was diagnosed with hypertension during a medical for a new job and advised to lose weight, exercise more and see his GP. So he cut down on sugar, he took up cycling, but he didn't see his GP until he developed a terrible headache a year later. When he was admitted to hospital, his GFR was 5 mils per minute, and he started dialysis right away 3 times a week. His coal plot, as you can see, do you remember TK's stopped at 40 and NG's goes up to nearly 60? Can you guess from right back at the beginning of the talk why his reactance, his dot might be higher? If you just guess in your minds, and then I'll tell you the answer. And the reason is that reactance depends on the current going through the cells, and the current can only go through lean tissue cells. And so the difference between TK and NG is that NG has a lot more muscle, so he has a higher reactance. That makes his coal plot taller. What happened to him was that his target weight was reduced to the lowest he could tolerate because he still had, he'd been diagnosed with hypertension and he still had high blood pressure. So it was thought that he must have excess fluid that was causing his blood pressure to be high. So this is when he was close to normal hydration. And if I go to the next slide, you can see that that's normal hydration, 90 kilograms pre-dialysis. And if you go to what happened to him at 91 kilos, and we actually found that his coal plot had gone right off the top. So we knew he was dehydrated. Yeah, so he's gone from being normally hydrated to dehydrated, and he's actually missing 4 litres of fluid post-dialysis. So he's gone normal hydration to underhydration, so he's moved up the seesaw. Yep. What happened next? Well, we'd just seen that he was 4 litres dehydrated post-dialysis. He was actually normally hydrated pre-dialysis, in fact. So we increased his target weight. He began to pass more urine. His interdialytic fluid gains fell. Previously, he was gaining at least 4 litres to get back to normal. His blood pressure control did not get worse. So we checked his residual kidney function and found that his GFR had increased to 9 mils per minute. He converted to twice a week, and we found he didn't need to have any fluid removed on hemodialysis. His kidneys were doing all the fluid removal necessary. His GFR continued to increase, so he converted to once a week, And then 8 months after starting hemodialysis, he was able to stop completely and just go back to a normal life. His GFR has been stable for 5 years at about 25 mils per minute. And so we now routinely do urine collections of various types on our patients to check their GFR and see if their kidney function is recovering. By the way, that's what paid for our electrodes forever, taking one patient off dialysis completely. Sorry, next one. And since then, we have found that patients who've been on dialysis for anything from 3 months to 5 years that we thought were chronic kidney failure could never recover. We've found a lot more of those patients are now recovering because we've stopped dehydrating them. These are three-year intervals starting from 1980, coming up to last year. And previously, if 1 in 100 of our new patients recovered function, that was about normal. Since we introduced BCM, we've had a massive increase in the number of new patients who are actually able to recover their function. And what's even better is that because we've stopped dehydrating patients at the end of dialysis when they've got kidney function, instead of patients, this is from the previous era, before 2010, this is how long the patients were able to stay off dialysis. So on average, they had maybe 3 to 4 years off dialysis. Whereas since 2010, we don't have as much data because we don't have so many years, but you can see that they're staying off dialysis for a lot longer. And we hope that many of the patients who are recovering now are never going to need to have dialysis in future. And I'll leave you with this young man who had BCM measurements from when he was 2 years old to when he was 4 years old and liked to help us. That's it from me. Thank you.